So it's my pleasure to welcome you to the Injury and Violence Prevention Seminar, Research to Practice Seminar Series. We do hold these monthly, typically the second Tuesday of the month at 12 p.m. And the timing worked out so well to have Joanna speak at this one. This is co-sponsored by the Centers for American Indian and Alaska Native Health. And before hi Erin, oh hi, welcome. Before I get started, just want to do some announcements. So this is our, I'm very excited. This is our first in-person seminar post-COVID. So glad to have an excuse to have something in person. But it is, for those online, it is being recorded, and we do share these videos in our YouTube feed and on our website, so anyone who couldn't make it today can still watch it. So as registrants, I believe you find right, Shelby, we tell everyone who registered that when the link's available. I think we can do that. I think we've done that in the past. Our seminar next month will actually be by the Firearm Injury Prevention Initiative. They have one coming up. I don't have a lot of details, so Erin or Sophie, if you know, I think it's about firearms and domestic violence and women and firearms. But we share any upcoming events on our website, and we have a newsletter you can subscribe to where we share events and other kind of useful information about injury prevention. Okay, so Shelby and I will be managing the chat today. If you have a question and don't want to interrupt, you can put it in the chat so we don't lose it. I'll help moderate questions at the end. And then I think it's a pretty small group online. It's a regular Zoom meeting. You are able to unmute and ask a question and to come up video, so you're not locked down in any way, like some other webinar formats. Okay, so now it's my pleasure to introduce Joanna Hikaka, who's a pharmacist and health researcher with clinical and research experience in older adult health, Māori health, and health services development, and has worked across primary, secondary, and aged residential care settings. She usually resides in Auckland, New Zealand, but is currently at Brown University, Rhode Island, as a Fulbright visiting researcher. And for those of you who joined early, I expressed my desire to do this someday, follow in her footsteps. Her current research focuses on pro-equity health intervention development. With that, I'll turn it over to you.
Thank you, and thank you very much for the opportunity to present today. So I just wanted to start by acknowledging that the University of Colorado's 4 campuses are on the traditional territories and ancestral homelands of the Cheyenne, the Arapaho, Ute, Apache, Comanche, Kiowa, Lakota, Pueblo, and Shoshone nations, and to acknowledge the 48 contemporary tribal nations with historical ties to the land that we're on today. And also to acknowledge that Brown University is located in Providence, Rhode Island, on the lands that are within the ancestral homelands of the Narragansett Indian tribe. And I guess in that acknowledgement, I acknowledge my status as a visitor on these lands, and acknowledge the people of the lands, those whose ancestors stewarded the lands, and the people who continue as strong sovereign nations today. So I'm going to talk to you today a bit about a project that I'm working on based in Aotearoa, New Zealand, and it's looking at a tribal-led injury prevention intervention for older Māori. So part of a Fulbright exchange is about it being a cultural, not just academic exchange. So I wanted to start by saying kia ora. That's an informal way of saying hello in Aotearoa, New Zealand. And it's actually Māori Language Week this week. So every year we have 1 week that's dedicated to the resurgence and restoration of the Māori language. And this is one of our tourist shots of part of the South Island, just to get people interested in coming to New Zealand. So New Zealand is located in the southern hemisphere. It is next to but not part of Australia. We have a population of around 5 million people, and I live in New Zealand's largest city, Auckland, which has 1.5 million people living in it. The photo on the top right is the beach. It is a 5-minute walk from our house. My daughter climbing around the cliffs. There's usually water over there, so it's a nice swimming beach. And the bottom right picture is Mount Taranaki, which is the mountain that I connect to ancestrally through my Māori tribe, Ngā Ruahine. Now, the New Zealand health system, I just thought I'd give you a little bit about that. As we go through this presentation, I'll talk about Māori, the Indigenous population in New Zealand, and then go into more detail around the injury prevention intervention that we're developing and investigating currently. So Māori in New Zealand make up 16% of the population, but that percentage can change quite a lot depending on the different regions. So it can be up to 70% of the population in some regions. There are over 100 different tribes in New Zealand and many sub-tribes below that, which the tribes and both the sub-tribes have active and effective governance and operational structures. And you don't have to be a member, like a signed up member, registered member, to identify with that tribe. It's in terms of our ethnicity data, it's a self-identified ethnicity, and that's how ethnicity is recorded in all our health records as well. So ethnicity as a social construct can change over time as well. So in terms of data, that can present issues when you're analysing things. The Treaty of Waitangi is New Zealand's founding document, and it is a legislative mandate which requires Māori to have equitable rights to originally British citizens. And it also gave Māori, British the right to govern New Zealand. However, it did guarantee Māori's sovereignty. So despite this legal mandate to ensure equal outcomes, we don't see that in terms of health. And that's mediated by the historical and contemporary effects of racism and colonisation, and also the flow-on effects in terms of the availability and access to the social determinants of health. So things like education, employment, housing, presentation to the judicial system, and healthcare access itself. And the inequities in health outcomes are a feature of the New Zealand health system, and regions with high proportion of Māori tend to have worse access to healthcare services. They tend to, Māori tend to, the higher regions, the regions with higher Māori populations tend to be more rural. And I think, and culturally, when we talk about older Māori, it's a revered position. So the importance in terms of the social and cultural capital that older Māori provide to our society is acknowledged within Māori worldviews. And in New Zealand, and it's becoming more mainstream, even in mainstream services, the role of older Māori within governance advisory groups is becoming more common, and in many cases a requirement, especially in relation to health. So the New Zealand healthcare system, and I call it a system because it really is a system, as opposed to the multiple systems that might exist in the US, has achieved pretty much universal health coverage through a mostly publicly funded, regionally administered delivery system. And the government dominates all aspects of healthcare as the primary funder and supplier of healthcare. It also sets the regulatory requirements and monitors compliance. Primary medical care is offered almost exclusively through general practice via general practitioners, which are equivalent to your family care physician, primary care nurses, and increasingly nurse practitioners with prescribing rights. Our general practitioners, or GPs, it's a cradle to grave approach. So, someone, my child who's a baby might also see the same physician as my grandparents. So there is really a requirement to have a broad knowledge when you're working in general practice. And for example, paediatricians and geriatricians would be accessed almost exclusively through secondary care in New Zealand with a primary care referral. There are no deductibles in the public sector. You don't have to pay anything if you go to an emergency department or hospital. Immunisations and cancer screening are usually free. Co-payments are required for primary care, so you can see the issues if secondary care, including emergency department presentation, is free, but there's a co-payment to attend primary care physician. There's often people with issues that could be resolved in primary care may present to emergency department because that's the only way they can access that care. The average adult co-payment, so children are all free, so children's medicines and visits under the age of 14 are all free. And the average adult co-payment for GP varies significantly, and it's based on where you live. So it's based on your address. It's based on the address of the primary care, the GP that you go to, general practice that you go to. And it can vary from $5 to $80. That's about what you might expect to pay. There are also co-payments required for services such as optometry, physiotherapy, and dentistry. Around 35% of the population have private health insurance, but private health insurance only makes up about 5% of national spend on health. And in New Zealand, private insurance is usually used for things like elective surgery, so joint replacements. It can be used to access cancer treatment a bit more quickly because you have faster access to those specialists. And for some cancers, that will make a difference. And you can also get the top-ups that it will fund your GP co-payment and optometry and dentistry and things like that. Another unique feature of the New Zealand healthcare system is our no-fault injury compensation scheme. So this is a government program and it operates sort of like an insurance company. So any injury is covered by ACC or Accident Compensation Corporation. And it covers intentional and unintentional injury and is no fault. So you could injure yourself falling off a bike, you could self-harm, you could injure yourself while committing an offence. And it covers the cost of care, but also covers the cost of loss of quality of life and loss of income. So it has, worker compensation. And because this actually operates like an insurance company, they have a really big interest in injury prevention as well as rehabilitation. It also creates consequences in terms of injury versus medical related care. So if you had a stroke and were paralysed, then you would not have as good access to care such as physiotherapy, orthotics, as you would if you, experienced a motor vehicle accident and then had ongoing consequences because of that. And so the project I'm going to talk to you today comes under the purview of ACC. Māori in New Zealand are less likely than non-Māori to have access to ACC services, and we know this at a general level, but ACC weren't sure about how that looked in the older adult population. And an example of inequities perpetuated by the ACC model, we can use something like workforce compensation. So if you're in a so ACC will usually cover 80% of your loss of income. So if you're in a job that pays $100,000 a year, you'd get $80,000 a year in compensation. If you're on a job that pays $30,000 a year, you'd get the proportion of that, so $24,000. So that's perpetuating inequities in resourcing in healthcare in New Zealand. So ACC weren't sure about variation in access to services for older Māori compared to older non-Māori. They also weren't sure about whether their services were adequately meeting the needs of older Māori in New Zealand. And so they put out a funding call for research broadly on this topic. So to investigate ACC access for older Māori. And we formed, at that time I was doing my PhD at the University of Auckland, and we formed a partnership with Te Aroha Whānau Water Collective, who are a Māori health collective who have 9 primary care practices underneath them. They are located in the North Island of New Zealand, about a 3.5-hour drive from University of Auckland, and we formed a partnership when the call came out, so we partnered to write the application. So our partnership was right from that point of developing an application. So it meant that we, from the beginning, could have shared objectives and methods that we, proposed to utilise. And that relationship, people at the University of Auckland had all worked together, so we've got a team of 11 or 12 investigators. People at Te Aroha Whānau Water Collective had all worked together, and there'd been some cross-working on various projects, but we never had a formal relationship between the two organisations. So Te Aroha is a tribe in New Zealand, and the area that it encompasses, crosses over 2 of New Zealand's regions for healthcare administration. So New Zealand at that point was split into 20 different regions for the provision and commissioning of health services. The area of Aotearoa has a population of around 35% Māori, and that's compared to Auckland, which is around 14%, so a much higher proportion of Māori. And a lot of so as opposed to Auckland, where you might get a lot of urban migration and many different iwi or tribes, in Aotearoa there's still a high proportion of Māori in Aotearoa being in the area of Aotearoa being from that tribe. And so I guess just a little bit about how I came to be on this project. I'd worked with some people in Auckland, and I'd had a sort of a relationship with someone through my PhD working in Aotearoa. But I think I haven't really worked in the injury prevention space before. I do identify as someone who is a long-term ACC service user, so I have a birth injury, which has resulted in a paralysed arm. But also I've been working in the health service research space around development of health services for older Māori, which is sort of seen as a specialist area as well. And we have injury experts, including injury epidemiologists, interventionalists working on the project as well. So we aimed to, I'll do this. The overall aim of our 2-year research project was to test the feasibility and acceptability of a Paeārahi-led intervention on injury prevention, treatment and rehabilitation, and the impact of that on ACC access for older Māori in that area of interest. So Paeārahi are like a community navigator. So they have connections in terms of in the community. They are members of the community. In Aotearoa, it's an unregulated workforce. There's evidence of efficacy of this type of role in other conditions, like diabetes, cardiovascular management in New Zealand, as well as delivering family-centred care, which sort of is a more holistic approach to care and health and social services. And they all can speak in Māori language and have good knowledge of Māori cultural practices. The history of navigation in Aotearoa is really strong. So one of their chiefs who navigated the waka, the boat canoe from Hawaii to Aotearoa New Zealand, Tamati Kapua, the stories of navigation are really well ingrained in their tribe. And so this role, you know, the members from Aotearoa always take us back to that historical place of navigators and importance. So in writing this proposal, we developed a name, Whaiora Ngāti Pā Harakeke, so that's the name of our project, and a logo to go with that. Harakeke is flax. So flax can be used for multiple purposes. It can be used to make twine and ropes and clothing, and for art, for things like the keti on the bottom right, the baskets. And a pā harakeke is a flax garden. And these flax gardens are a central part of a traditional Māori sort of settlement. And they were always planted with thought and care as to the type of plants that would go into them. So plants that would grow well together, but that would complement each other. They might be diverse and different, but they would sustain each other. Whaioranga means the pursuit of wellness. So it's talking about, so in terms of our project team coming together, it's collecting all the different strengths of the people within that to, you know, pursue wellness. And that's seen through the strands of the logo as well, intertwining to become a stronger unit as one. So the project we proposed was a multi-phase project. First, we examined the evidence base for you know, types of injuries that were seen in this area, but also look at international evidence around what type of interventions might be useful. We then worked to co-design the actual intervention. We're currently in phase 3 where we are assessing the feasibility and acceptability. And phase 4 is when we will synthesize recommendations, and our whole approach is that this is intended to be a sustainable, we're trying to develop a sustainable model of care in the area. So, I'm talking to injury experts here. So we looked at the national and international literature. We know that for older people, falls prevention is a really important intervention. And the types of interventions around that might reduce the risk of falls are things like home assessment and modification, so identifying hazards in the home and then acting to remove those. A health assessment, so understanding comorbidities or things like eyesight, vision, orthotics, ability to walk around the house unaided. Strength and balance exercises are really important. And also social connectedness, so the impact of loneliness on falls and sequelae of falls. Other types of injury prevention, and sorry, I should have said this is all unintentional injury that we're looking at. So we excluded self-harm and assault from the phase 3 data. So other types of injury prevention, we know that driving assessments can make a difference. Safe community, so understanding risks within the community that people move in. That smoke alarms can reduce injury from burns and house fires, and the issues with gardening, so making gardening safe. In terms of Māori focused research, there's evidence that home assessment and modification can be of benefit to reduce injury. Interestingly, this study was only done in those who owned their own home, because the complexity of managing home modifications and rental housing was felt to be outside the scope of that project, but it has, that has ramifications in that Māori are less likely than non-Māori to own their own home, and so there's the exclusion of people in that position. And there's also evidence in terms of Māori focused research that strength and balance exercises are beneficial, but that's in the context of Māori-led design of the strength and balance programs. So we looked at the primary data in New Zealand. I didn't talk about this, but we have large national data sets. So as researchers with ethics approval, we can access data for all the injury claims in New Zealand, and that's we can link that to the hospitalisations related to that. We have all the hospitalisation data, mortality data, and so the ACC claims data also includes the amount that's compensated, so the cost that goes into that care, the type of injury, where it occurred, the preceding event. So it's quite a lot of data, and we have that at a national level. So for our 2 regions, we wanted to investigate the incidence and characteristics of unintentional injury in older Māori. And just briefly, we found that compared to non-Māori, Māori were about 15 years younger at time of injury. So we looked at everyone 50 plus. So that's just in the older adult cohort. We use a younger age because in New Zealand, these inequities in access to the determinants of health lead to shorter life expectancy for Māori, approximately 7 years on average lower than non-Māori. And so we're seeing that even though the life expectancy is only 7 years lower, injuries occurring at a younger age. And the reason we did this analysis is to understand how we might need to focus our intervention. So the majority of injury was happening in the home. The majority of injuries were falls, and the type of injury were most often soft tissue injury. We excluded treatment injury so we have access to treatment injury data as well, because that also comes under ACC, but we excluded that from our analysis. But we've actually got a medical student working through that data at the moment, and it's showing inequity. So Māori are far more likely to have treatment injury related claims, which is a potential proxy for access to healthcare, or access to high quality healthcare. So the second phase was to co-design this intervention. Now, New Zealand did have a good COVID response. Part of that was because we had intense lockdowns. So our Auckland team could not leave our house, effectively our homes, for 6 months. But geographically, Auckland is really easily able to be excluded. It's on a very narrow piece of land, so the borders can be monitored. Flights were not going in and out of Auckland. You had police on the northern and southern borders of Auckland, so people could not leave. You could get a special work order if you're in an essential service. So a colleague of mine was a pharmacist in Auckland, but had to work south of the border, south of the imposed border, and so had to go through the security checks every day to do that. So this is a picture of the Aucklanders in their homes, and then the tiny people at the bottom are everyone else that it was in Aotearoa or Aotearoa area that could meet while we were having these meetings. So we put this proposal together during the time of COVID. So it was in middle of 2020 when we were thinking, when COVID's over, we will and then we had COVID-free period in New Zealand, no COVID in the community, like 0 cases of COVID in the community for probably 6 months. And then Delta came to New Zealand. And so this picture was during late August 2021. So to design this intervention, and it was always going to be Paeārahi led, so the community navigator led, so that was our core component. We interviewed over 50 older Māori families, people that were already working in the Paeārahi role but not with an injury focus, and other stakeholders involved in injury prevention in the region. We also utilised research team expertise, developed sort of draft models of what this intervention might look like, and also had a Aotearoa, so a tribal advisory group, and that advisory group has members of the Aotearoa, and they have experience in education and training, Māori cultural practices, physiotherapy, evaluation, and so they've been involved throughout in terms of what the intervention looks like and delivering that. So as part of those phase 2 findings, so the intention of interviewing people was to develop the intervention. If we look at it just from a sort of a very, biomedical approach to this research, but we found lots of other findings that we've had to feed out back to the other stakeholders. So, changes in how ACC provide their service. The people used to have a key worker so there was that point of contact that was changed. So now you have to access ACC through a call centre. So you could speak to someone that doesn't know you at all. People talked about fragmentation of care, the fact that services were not culturally safe. So the rural isolation faced by some people. So parts of the Aotearoa area are quite rural. Also talked about enablers of good injury care, enablers of wellbeing, and enablers of injury prevention. So people wanted to get care from trusted providers. They wanted a holistic approach to injury prevention. So a lot of people talked about the fact that everyone was focused on their physical injury, but didn't think about how it had affected them mentally, being in hospital for long periods, being isolated for long periods. And also talked about the other community allied health opportunities and the ability to connect in with those. People talk of the desire for proactive injury prevention, so getting it before it occurs. They wanted increased opportunities to connect together, share and socialise, and that could take part around a physical activity program as well. So they talked about kapahaka, which is traditional Māori song and dance, poi, which I will show you a bit later, which is a ball on the end of a string that spins, and things like low intensity Zumba and Te Reo Māori, so the Māori language. And that's another, Te Aroa still have quite a high proportion of people that speak Te Reo Māori comparative to the general population in New Zealand. So we've now published our study protocol. We actually were aiming to do an efficacy trial, but we had to change the study design. We were going to do a step wedge design where the practices would start the intervention at a different time, but because of the cohesive nature in which the 3 study practices worked together, they didn't think that we could effectively isolate the knowledge and learnings from one practice to another. So, and because we recognise that this is a new model of care, we're focusing more on the feasibility and acceptability now. So what is our intervention going to look like? We have Paeārahi visiting the home, at least 4 visits over a 12-week period. And again, we just had to sort of draw a line in the sand in terms of how many visits and the period over which that would occur. many people are already saying that that could be longer or shorter dependent on the needs of the person, the older Māori and the family. So the intervention is at an individual level in terms of recruitment, but we can also recruit family members, and we support family members to attend these visits and feed into things. A whānau order assessment. So whānau order is like a family wellbeing, and this is a assessment that's already up and running and administered by Paeārahi, and it looks at multiple determinants of health. So it asks about their mental health, social wellbeing, stresses, that kind of thing. We put together a mini health assessment, so the Paeārahi will administer this mini health assessment and feed it back to the primary care physician. So it's things like, do your shoes fit well? So bearing in mind that this is an unregulated workforce, we're just, I guess, increasing access to these types of assessment without the expectation that Paeārahi themselves will put an intervention in place around some of these health things. And there's a flow diagram of, dependent on answers, who should be contacted and referred. They undertake a home assessment, so identifying hazards in the home, but in a way that tries to get the person and their family to know to look out for that ongoing, so that it's not, it's more of a sustainable approach. We had intended that they'd be referred to the local exercise program. However, phase 2 and engagement with other stakeholders through that process, we realised there were no culturally appropriate health exercise programs in the area, so we had to work on then creating that, and education was a big thing. So understanding injuries and how to prevent injuries, but also educating around how to access injury-related care. So we're going to look at acceptability as our primary outcome, and also do some exploratory efficacy work, and using those national data sets to access things like injury claims and hospitalisations. And we'll do a full process evaluation as well, so understanding what actually ends up being delivered from the intervention that we propose at the outset. We are trying to make this a sustainable model of care, and to do that we're wanting to include stakeholders throughout, and be having conversations earlier around what evidence might be needed to have longer term funding, and so we have 8 weekly Zoom meetings with anyone who wants to attend. So we send it to stakeholders that we think are related to injury prevention in New Zealand and regionally, but we also say that it's an open invitation. So in theory, the general public can attend too, anyone can attend. And we circulate these sort of very high level, simple documents with each of the meetings, just to let people know where we're up to and what the next steps are. I talked about the Iwi-led strength and balance program. So one of the key findings from phase 2 was that there was no appropriate strength and balance program. So this is an Iwi-led research program, and so the Iwi wanted to develop something specific to their area. These are poi, so it's a ball, soft ball on the end of a long string, and people spin it around. I will just, now let me know if this is going to affect people on Zoom. So maybe if we just let me know if this is just a 1 minute clip about poi.
The queers did at that time. By doing the poi today, okay, we're emanating there.
Okay, that's okay. So I did have a video, a 1 minute video about poi, but basically it's a poi is a softball on the end of a long string. But when you're doing the poi, there's physical movements that are required. So there's hand-eye coordination. So the fact that the ball goes on your back and hits your hand, and there's spinning. There's twisting, so people twist as you do it. There's also sort of footwork, so moving forward and back and that kind of thing. And so we're working with a local Māori physio who has sort of been supported through this research process to really start thinking about their own clinical practice and how they want to provide care, and he's supporting the development of the local strength and balance program that incorporates tribal movements. So although we can talk about Māori as one, it's a diverse, Māori are diverse, and there's different songs, different ways people move within those songs that are important locally, and so they're all being incorporated into the exercise program. A big thing also was that people wanted this to be a social occasion, so the exercise program could provide social connection. And so this is a picture of some of our participants, and at the very far end of the room is the physio. We can see him here doing the actions. He's on the right of the picture, and everyone's joining in. There's modifications for if people can't stand. Part of the intervention also required the Paeārahi to be trained in injury specifically. So although they had wide skills in terms of community connection and understanding resource that was available in the community, upskilling around injury specifically was required. And so this is a picture of two of the Paeārahi that were employed specifically for this research program. So you can see one of them's wearing gumboots because some of the areas they've just been visiting were a bit muddy. And you can see also that different ages of Paeārahi, so also bringing diverse skill sets individually. And that's important for how people connect. So the older people might be connecting more on a peer level, whereas the others it's more of that child-grandchild relationship, which can be quite, and within Māori culture that's really the grandchild, and other cultures as well, but grandchild and grandparents, a really special connection, so that helps to develop relationships too. The course we're developing, we are getting it accredited nationally so that it can be like a micro-credentialing course that's added into, so they're already general Paeārahi training modules, so we're doing the injury prevention one as a micro-credentialing course. And I just wanted to talk a bit about the benefits of partnership, and this is I'm thinking between like the community organisation, the Māori health provider, and the academia. So we've been able to have a diverse expertise around our research table and mutual learning. So everyone in our team is always learning from the different skill sets that we have there. There's lots of things that as us researchers sitting in Auckland would not have been thinking about. Compared to what people on the ground are understanding, even using COVID as an example. So because things were happening quite differently across the country, understanding what was appropriate locally, whether our Paeārahi could go in and deliver an intervention and the restrictions, all that kind of thing was really important to have people there on the ground doing that. We weren't able to undertake this research during the pandemic, so I'm not sure if, it would have been the same here. So health providers completely slammed by work requirements. But because the providers were engaged with this project, felt it had value, they were still really keen to see it progressing as it could through COVID. We've trying to talk about tribal engagement and control in the research process. So trying to be really good partners and ensuring that people like the stakeholders and the funders recognise that. So the university are the main sponsors of the project, hold the main contract, and we've and that was at a request from Te Aroha because they hadn't had experience managing large research projects before. But that means that you're always the one contacted to make decisions, funders still contact you to make decisions, to present, to be somewhere, and that's not how we want to operate. So it's always about putting it back to ensure that the tribe has representation there. Been a strengths-based approach to research. So at the moment, we're having to review all the assessments that we're doing because we have incorporated a large number of assessments, and it was feeling like the research processes were interfering with the intervention. So we're managing that now and thinking about how we ask those questions, so that it's not necessarily sitting down and just asking the questions, but they are incorporated in engagement and can be recorded at a different time. Or we'd set up tablets. There's a tablet there for data collection, but that itself, because we thought that would be efficient and good, and that was what we thought would be best at the time, but that seems to be a barrier in delivering the intervention too. So there's been ability to resource align. So within the research project, you can see that that box is actually sort of a wellness pack that is sent out to people in the area. That's from a different program of work compared to the research, but it means that there's alignment of resources that can be taken at the same time that the research is happening, and that helps develop relationships as well. It's already starting to have impact outside the contracted research objectives and milestones. So we're seeing stronger relationships between primary and secondary care. We've seen the example of the Māori physio who's changing how he practices and feels supported to do that. And there's already some contracts coming through with similar types of models of care within the area. So that's been good. And what we've also been trying to do is build up the Te Arawa's research capacity so that they do become into a position where they can manage research projects like this in the future. And then I've talked about the last point already. And we will reflect formally on this partnership at the end of our project. So we all have a chance to talk about, that and learn from that experience. And just finally, acknowledgements. So the funders, ACC, but also New Zealand's Health Research Council and Ageing Well National Science Challenge in New Zealand. And the fact that I'm here on Fulbright and HRC funding. And most importantly, the other research team members and our participants, who this project wouldn't obviously be anything without them. That's all I had to talk about. Answer questions about anything, including Fulbright. People are wanting to ask about. This is that same beach. So this is the beach I live 5 minutes away from. So wherever that's gone. Yeah. So yeah. Okay.
All right. Well, it's not a big group, so if you're on Zoom, you can raise your hand if you want first, or you can just unmute and dive in. I know you can't see us in the room. And maybe I'll ask a first question to get us going. Which one to ask? I have two burning questions. I'll just start with one. When doing an assessment of the home, if there's a sense that some modifications are needed and they're quite costly, I'm thinking of like bathrooms in particular, that modify, like removing rugs, removing furniture. I can imagine the easy things and then things that are expensive. Is there funding then to do something larger scale?
Yeah, and so that's how the Paeārahi are connecting into those funding resources that already exist or helping people access that emergency funding. So one example is because of the relationships developed through this project, a family had an urgent issue with their bathroom, and the regional commissioners of service, so the district health board, were able to provide alternative accommodation for that family of 6 that were in a small home for the 2-week period that their bathroom urgently got attended to. And so that they are the kind of things that the Paeārahi have a role in sort of navigating. Where do I go for that funding? Who do I ask? How do we action this? Because that's the thing. It's one thing to identify the hazards, but there's absolutely no benefit to injury prevention if nothing's done about that hazard. So, yeah.
So just did ACC pay for that then, or are there others?
No, so that's not ACC. So that's through community funding that already exists through social and health services in the area. So
that's phenomenal.
Yeah. Yeah. So no, ACC, they would pay for modifications if so this was because an issue happened with the bathroom and it was unusable, but ACC would pay for modifications if it was from an injury. So for example, stroke, you wouldn't get modification of stairs, but if you injured, if you had a broken leg and the only way to get up was to get up these stairs, then modification might be funded.
But that's a reaction to an injury versus preventing an injury.
Yeah.
Right? I mean,
yeah. And so there's different people will have different needs. So in that phase 2, we interviewed people that were stuck in one room of the house because they were sitting, their living area was upstairs and their bedroom was downstairs, and they were stuck in their bedroom because or the living, I think they were stuck in their living area because that's where the bathroom was as well, and they'd just been stuck there because they hadn't really known who to ask, or that was an entitlement, so that it was possible. So that's the thing. So if you don't actually know that something could be done, then yeah.
The question on chat that I can read from Jim Russell. Did you use an already standardized algorithm to determine fall risk? And did you use an already existing checklist for the home assessment?
So the home assessment was an already existing checklist, and that's from ACC itself, because they obviously invested in that. In terms of risk, there are 3 study practices in this, and each of the study practices is determining it themselves. So we know that the resourcing for this research project so everyone 55 that's Māori, 55 and over that's Māori, and is enrolled in one of those practices is eligible for the study. So we haven't built risk stratification into participants' ability to participate, so eligibility criteria, but each of the practices has decided. So for one practice, they've decided that they're going to focus on everyone that's already had an injury, because had an ACC related claim in the last 3 months. So whereas another practice focused on all their older adults first, they wanted to contact them, and then the other practice was talking to the entire healthcare team about who might be most appropriate. So there is variation in that, and so we just have to write that into how we've done the research.
Can you say how many people participated or are participating, and how you recruited them, or how they landed in the study?
Yes, so our intention is to recruit 150 individuals and an extra 100 family. So our primary outcome is acceptability, and the measure we're using is a Māori validated tool that triangulates the individual, the family, and the provider response. And so target recruitment is based on the size of the practice. So 2 practices are bigger than the other one, and the 2 practices have 2 Paeārahi, 1 practice has 1, and we're aiming to recruit 30. So we're aiming to recruit 150. So each Paeārahi over a 12-month period will see 50 people. And that's similar to their normal work, what a Paeārahi's normal workload would be, to have maybe 20 to 30 people on their books at one time. So recognising that the Paeārahi are also doing some of the assessments, so baseline and post-intervention assessment, things like timed up and go, fear of falling scales, measures that were designed for the study around confidence and accessing injury-related care.
And how did the word get out?
So they look at the practices are recruiting themselves. So the 3 practice managers are research team members, so they are managing their lists, and they contact, either the manager contacts them because they have a relationship, or the Paeārahi will contact them. Sometimes the Paeārahi sits in the waiting room and talks to people. So interestingly, even though these relationships exist, recruitment still hasn't been that easy because people have other areas of focus, so other priorities. So injury prevention, when they haven't had an injury, isn't their priority, particularly at the moment. So when we were supposed to start this intervention is when Aotearoa started getting COVID. So although we've had a lot in Auckland, it eventually went everywhere, and that's So although this was a 2-year project, we've got an 8-month extension, so no cost extension to
I just actually, as a family member, is quite interesting to me this, and you mentioned triangulating data. Are they being asked the same questions, or are they just part of it? Are you accounting for their involvement in some of their analysis? I'm just curious.
So we will know whether an individual has a recruited family member or not. They can participate with the individual without being a recruited participant themselves, a family member. So they can participate and be involved. The only reason we need them to consent is if they're doing that formal assessment. Now that assessment is called the Hua Oranga tool. It was originally designed, interesting, by Sir Mason Jury, who apparently Professor Manson spent some time with in New Zealand, and Te Kane Kingi, and that was, so it asks across 4 domains of health, which is physical health, mental health, spiritual health, and family health. And so it asks questions like, how did this intervention impact on your ability to connect with others? How did this intervention impact? And then for family members, it's how do you think this intervention impacted on your family members' ability to, and then for the providers, how do you think this, so,
One more question. You mentioned actually like models of care. I'm curious as to how you see this growing for whether it's ACC investment or that kind of group of funding that they can access. Like, what would you see this coming? Sustainability was named.
And so I think there's the model of care in terms of injury specific. So knowing who to contact within, say you've got a team of 10 Paeārahi, but knowing who to contact if it's an injury, if there's a person whose main issue is around injury or injury prevention. It's also, so ACC are really interested in this model, being a funder, they're invested and they're attending those stakeholder meetings and we keep up to date with them. There's the use of the Paeārahi with the fracture liaison service. So I don't know if you have fracture liaison services, but in New Zealand we have a team based in the hospital. So if someone's admitted with either with a fragility fracture, then there's a team of people that assess them and then coordinate care out in the community. So there's new funding based on that to support that model. And I think what's really important for us to record is how that resource, like I talked about shared resourcing. So the Paeārahi, although they're a research Paeārahi, they might take that wellness box with them, or they might, they're connecting them in with other, so that like the exercise program, that's another area for funding. So that developing an exercise program fell outside the scope of our research project, but we needed to do it. So developing the funding, not only to develop the program, but for that service to continue long term. So working with physios and other people. So interestingly, ACC already have programs like that delivered in the area, but none that was specifically designed for Māori or with Māori. And so, petitioning them that there needs to be equity and resourcing of that type of service.
I have another question to pause in case someone else wants to jump in. I'm curious about the claims data and if there's much detail there in terms of the circumstances of like a fall or an injury. And I guess I was thinking about how there's a model where like with child fatality reviews, there's a team that can review it and then think about prevention strategies and inform community level prevention. And it would just be so lovely if that surveillance data or claims data had details that could then, feed back into strategies.
Yeah, so we know that, whether the injury was from a motor vehicle accident or we know that the person was running before they fell. So we know that they were running before they fell and then it resulted in a fracture for that individual. So there's that sort of level, and we know that that individual then received this treatment and it cost this much and they got this much compensation. And
yeah, it's not like a narrative or something that could be abstracted or
not without doing that analysis first. Yeah, which is it's always, it seems frustrating that researchers are having to start this from the, when you think that there'd be analysis, analysts that might be able to just do it.
Yeah.
Because there were issues with accessing the data. It took a long time. There'd been some publicly reported breaches of privacy in ACC, and therefore getting access to this, because ACC hold their data, the other data is held by our National Ministry of Health, but ACC hold their own data.
This is a very specific question. So you talked about the tablets and how they were a barrier to implementation and how collecting data was becoming. I experienced this in the community too. So I'm wondering if you can talk more a little bit around how you made that work. You mentioned after the fact you can enter data. It sounds like they want to be conversational.
Yeah.
Want to ask a ton of questions, but just your experience with that.
Yeah. So the research project provided tablets. We also had to provide we had to sort of make the forms for this. Some of them were forms that already existed, but maybe not as easily accessed through electronic methods. So some people have been able to use the tool better than others within the, people collecting the data. So we've just said we can print them off and you can do them either at that time, like you're talking and you're sort of, it's easier. Sometimes it is actually easier to do it physically, or you just do it in the car afterwards.
Just like, so you have like the probing questions type thing. So
Yeah. And I think also none of the Paeārahi had experience in research and also limited experience in that. So some of them had more experience than others in terms of how you talk to people and ask questions without actually asking questions, and the little jokes that you make, and you make it with every single person, but that person doesn't know that, and so we're thinking now that we're going to have to also think about how we analyse the data in terms of who was originally recruited compared to those that are recruited later on in the process, because people's Paeārahi themselves, their confidence in delivering the intervention and doing those assessments is increasing as we go along. So yeah.
We're almost at 1, so if there's not any further questions, we can perhaps if people can have a minute before their next Zoom.
Okay. Thanks everyone.
Thank you, everyone. I know. Thank you. Yeah.
Thank you very much.